make sure that we are using your time in a way that is respectful. I'm Brianne Nadeau, a council member in the District of Columbia. I'm the chair of the coalition. Our vice chairs are Will Jawando from Montgomery County, who is here with us, and Penny Gross from Fairfax County. And normally we go around and do a bunch of updates in the beginning, but I am going to focus us on the content at the beginning today and at the end. Hopefully we'll have time to do some jurisdictional updates. As a policy committee of the COG Board of Directors, our Region Forward Coalition is tasked with helping realize our shared vision for prosperity, accessibility, livability, and sustainability, anchored in a commitment to advancing equity. We do this in a variety of ways, tracking our region's progress towards specific targets, sharing strategies and best practices amongst our diverse membership, and often, like we're doing now, elevating issues so that we can have constructive conversations among area leaders. Today, we're going to focus on the importance of providing support and services to our immigrant communities within our region. And this is something that in the past we've done willingly and well. It's something I'm very proud of about our region. And today we're gonna do two things. We're gonna talk about what is becoming a crisis in the region, welcoming of the migrants from Arizona and Texas, and also we're gonna talk about the healthcare benefits that we provide across the region for our immigrant residents. And we're gonna have two separate panels. Before we jump in, I am gonna hand it over to Chuck for some COG updates. He's the only one who gets to go first. He's the big boss. So Chuck, did he make it yet?
This is Paul. I don't think Chuck is actually on, so I don't know if you want me to go in his stead or if we just want to move into things.
That's your call, sir. I don't know. Can you go in his stead?
Well, I can at least cover one or two of the announcements, one of which is the COG Board Leadership Retreat will be occurring next week. And several of the things we'll be focusing on are sort of the post-COVID realities of the world and how we would be moving forward with that. And the other reason we had Chuck teed up, in case any of you on this call are not in fact aware, Chuck will be leaving the Council of Governments early next year, and we'll be beginning the process to seek his replacement. It's big shoes from the staff who have worked for him all this time. So those were the two announcements, Madam Chair, and I see that your other Vice Chair, Supervisor Gross, is now joined. So I think we'll turn back to you and the leadership for any other announcements from you all.
Great. And speaking of post-COVID, I currently have COVID. So if you all could just give me your grace today, give me a little grace today. I'm at a standing desk, but I might have to move. So it's not about me, though. The good news is most of the speaking will be done by our wonderful guests today. So our first panel
Brianne.
Oh, yes.
Go ahead. I don't know as long as I don't know which order you're going in, but I wanted to make a few comments before we started.
Yeah, sure. Go ahead, Will.
Yeah,
Mr. Vice Chair, go ahead.
Thank you. And I hope you're feeling better soon. Appreciate everyone joining and coming together for this discussion. You know, it's been really a joy serving on this Region Forward committee for all of my 4 years of my first term. And I think we touch on a lot of very important issues. But the one we're talking about today really is one of the two issues we're talking about today is approaching crisis levels. And I'm really thankful for all the work that's been done up until this point to respond to what is an untenable and immoral situation that's been created by Governors Abbott and the Governor of Arizona to send residents of their states to make a political point and put families' lives in jeopardy and in the balance and destabilize communities and residents to make a political point, sending people to our region that are immigrants of various statuses from various parts of the world. And I'm really proud of the work that's been done by the faith-based nonprofit community, and we'll hear from some of them, one representative from that group, but it's been a much larger effort in our private sector, nonprofit community to come wrap around and make sure that these residents, though through no fault of their own, have been put in this situation, that they have respite and that they can get to somewhere where they have relationship to family and friends elsewhere in the nation, in the country. And I'm proud of what Montgomery County has done to be a part of that effort and to provide that respite as people are coming through. And, you know, you'll hear from Dira Treadvance, who's doing a great job at our Department of Health and Human Services and talking about specifically what we've been doing, and also from SAMU later. But I think the point needs to be underscored that this is increasing, and the number of people is increasing, and we need to have a regional response. And I want to thank Brian and the DC Council for their work this week in making that point. And part of the reason we're having this discussion is to emphasize that this is something that an issue that we didn't create, but that we have to deal with, and that as with all things, as I tell my kids, you know, when you do it together, it's easier to come up with good solutions. So with that, I'll pause, but I just wanted to give that as kind of an intro, and I appreciate that, Brianna.
Thank you so much, Will. And our other vice chair, Penny, has stepped off camera for a minute, but she always leads us off with really amazing questions during the Q&A. So that is one of her very important roles here. And we will let her make some remarks as the other vice chair then. So we have, actually, we added a panelist today. We have 3 great panelists. So, you know, Will, you laid this out really well, but for the past 3 months, we've received buses of asylum seekers from the border to the district, involving more than 100 buses and carrying more than 3,400 people. Often these migrants arrive with only the clothes they're wearing, with no way to continue their travel to their sponsors due to the lack of resources. So we're going to hear today from Dira Treadvance, who's leading the response for Montgomery County Health and Human Services, Tatiana Laborde from SAMU First Response, which is an international humanitarian nonprofit who's providing services and sheltering migrants on a temporary basis, and also Amy Fisher with Sanctuary DMV, who's been one of the leaders coordinating the robust volunteer response since the first bus arrived until now. And I'm excited for you to hear about what so many people from around the region have just done to pitch in. And I'm sure you know your own constituents have talked to you about this as well, but the volunteers have carried so much. So today, our intention is not to focus on the political aspect of this response, because we're COG and we know the rules. I'm just teasing, Paul. The purpose of our discussion is information sharing and an improved understanding of the issue for member jurisdictions, right? For me, this is, I know not everybody is up to speed. I've been living this and breathing it like many of our panelists and leaders in the region, but not everybody has. So it's a really important opportunity for everyone to understand the situation on the ground. And from there, we also want to make connections to available local resources and identify possible partnerships. So we're not defining, organizing, or directing how responses are administered by these jurisdictions. That's not our role, but we are trying to facilitate these connections. Jenny's going to place a link to a Google spreadsheet that we can use today and beyond with specific asks and needs from those doing the work. And that's still being filled in. And then folks can join in and add offers. So, you know, if you have a nonprofit in your area or a church or a volunteer group that wants to get involved or donate a specific item, you can add that in there and we can keep everybody connected. Now, Will, do you want to, you're going to introduce Dira. You kind of already did. But did you have anything else you wanted to say there?
No. I think I did my job. Dira's ready to go.
All right. So then we'll start with Dira, who is the Chief of Children, Youth, and Families at Montgomery County Health and Human Services. Dira, you're up.
Good afternoon, everybody. Pleasure to meet you, and thank you so much for having us here on your platform to be able to just talk through some of our lessons learned and a little bit more on how we've approached our coordinated response around this very critical issue and need. So next, is that what I say next? Thank you. So we all know how all of this started. It started back in April 2020. We started receiving an influx of buses coming in from Texas, and then Arizona followed suit. Most of the newcomers at that time, we were seeing that most of them didn't really want to stay in the area. They really just had a second destination and had another location to go to. So our initial support and services really was centered around helping and assisting with travel. Immediately, our community-based partners showed up, and they were able to expeditiously, just sort of as much as their bandwidth allowed, they were able to show up, welcome the individuals coming in, and really offer them support and services. Next slide, please. Montgomery County, what really worked well for us is we sort of had an infrastructure already in place that allowed us to be able to be more flexible and to be able to coordinate a response. As you know, Montgomery County has made a commitment to serve all newcomers regardless of their nationality. So approximately I joined the county back in January, but I joined in right when an initiative was launched to really serve the newcomer population. So we already had that infrastructure in place, which allowed us to be able to provide. It's a network comprised of multiple stakeholders, and the network is richly staffed to be able to meet the various needs of this population. So because we already had that in place, it really positioned us well to be able to respond in a manner that was effective and also expeditious, and work in partnership a lot easier and seamlessly with our community partners. But there were still challenges. It wasn't easy. I know I said the word easy. It just really allowed us to sort of step into the picture, but we still encountered our own challenges along the way. Next slide, please. So we really started to initially at the beginning in April, our initial response really looked like us working. How did that look like? It looked like us working in partnership with our community and faith-based organizations. And we were assisting with providing shelter, finding housing for families and individuals, assisting with travel, offering medical support, COVID testing, food, and other resources that these individuals and families needed. What was great, before SAMU came into the picture, it was really a big turning point. We served approximately 170 people. And then the big turning point for us was when SAMU's really centralized respite support. And that's when it really was a turning point. I know I'm repeating that same word. So when SAMU came in, we were able to centralize respite services. So all of the individuals coming in from the buses, SAMU would meet them, and the individuals would be taken to the respite center where they had resources to be able to, food, shelter, basically their basic needs were being met. So we pivoted then. Our support then for the Newcomers Network and the infrastructure that we had to look a little bit differently. We were no longer doing some of the pieces that SAMU was doing, because that organization was really taking hold of like that initial first step, centralizing the supports and the services. So we pivoted then. The Newcomers Network that we had pivoted to serve only the individuals and the families who did not have a second destination and decided to remain in the region. So those have been the individuals that we have been working with. It's been challenging. We have huge capacity issues at the moment. Our network, our providers, the need is more than what our providers have the capacity to meet. So those are some of the challenges that we're experiencing. What worked well for us is that we really were able to define what support looked like, and we were cognizant that at the beginning, at each juncture of this process, support from the county needed to look a little bit differently. So in the beginning, we were proactive in really working with the community-based organizations, meeting folks at the buses and really getting their needs. But now that SAMU was in the picture, we pivoted and our support started to look a little bit differently. We would not have been able to be successful without our community-based partners. They really held this down. They really stepped up to the charge, to the call, and they really were able to help us stay afloat. So we would not have been able to have the impact that we have had if it wasn't for their support. Another area that really helped us and we're still kind of grappling with, right, is the ability to be and have a posture and an openness to explore innovative, equitable solutions, because this group has different needs than the traditional folks that we serve, which requires new innovative solutions, mantling a new system that is able to more expeditiously meet the concrete needs of this specific population. It's still difficult because, government, we exist within the confines of the systems that we operate in. So it's very difficult sometimes to be able to pivot and really think about what we could possibly do because we also have our limitations. So really challenging ourselves to find truly equitable solutions for this population is something that we continue to center in our conversations. What else I wanted to offer? Sorry, not yet. If we could go back to the other slide. What else? I just wanted to offer some of our hurdles. One of the things that we continue to also grapple with is after we've been able to help, we're really trying to help the families remaining in the region. Helping them find employment has been very difficult because they don't have legal documentation. So we've been working really hard to try to get to see if we can address that because while we might be able to help find a limited amount of hotel stays, we really want to anchor them into the community and so that they could be, so that they could start thriving and meeting the needs of their families. So that's been really a big challenge for us. We've been engaging with hotels and facilities for short-term lodging once they migrate out of the respite centers. And right now, the profile of the individuals is shifting. In the beginning, we were seeing the majority of folks kind of choosing to go to second destinations, but I won't go into those details because Tatiana from SAMU is going to give a better profile on what we are currently seeing and some of the additional issues that we're grappling with. But this is just brief recap on the infrastructure that we had that really helped us to respond and how we pivoted support once SAMU was able to be in the picture and be a collaborative partner with us, and also talking about some of the issues that we continue to grapple with, which is around capacity for our providers. The need is vast, but the resources in terms of like human and manpower are still very feeble. So now I'll pivot it over to Tatiana. I know there might be more questions later on and I'm happy to respond, but I want to hand it over to Tatiana. She'll speak a little bit more on what SAMU is currently seeing.
Thank you, Darren. Thank you for all the support that you have given us over the past couple months. My name is Tatiana Laborde, and I am the Managing Director of SAMU First Response. If we can go to the next slide. So we, after the arrival of the migrants from Texas, we submitted a proposal for the PMI EFSP program, and we have been granted an award to serve migrants coming into Washington, D.C. Next, please. Yes, can we go to the next slide, please? Okay, so while that comes up, just a little bit of background. We're part of an international
I think there might be an issue
organization.
with your connection.
Yes?
I think there's an
Hello?
issue with your connection because your video is coming in and out, and I think the slides are flipping up, but you can't see them.
Okay.
Might have you just turn your video off to save your bandwidth, and then yeah.
Okay.
Is this the slide that you wanted, or was
it?
it the prior slide?
Is it better now?
Yeah. Is this the slide that you wanted, or is it the prior slide that you wanted?
Hello? The next slide, please. Can you guys hear me okay?
Mm-hmm. Okay, now we can't hear you at all.
While we wait for Tatiana's connection to come back, I'm happy to answer any questions folks might have.
Oh, thanks. I think if we'll do questions at the end. If Tatiana's having trouble, we may just go to Amy next. Let's give her one more second to figure out. And I actually do think she meant to be on a prior slide. I just think she's not seeing them come up. Yeah, I think that's where she was when her audio cut out. All right, well, let's pause on Tatiana. And I'm going to call on Amy Fisher of Sanctuary DMV. Amy has been working with a very robust volunteer response that has been on the ground, and can share a bit of that. She is ready.
Thank you so much for having me. So good afternoon, everyone. As Councilmember Nadeau said, my name is Amy Fisher. I've been living in the DMV for about 9 years. For my job, I lead Amnesty International's U.S. advocacy on refugee and migrant rights, but today I'm here in my personal capacity as a volunteer with Sanctuary DMV and the Migrant Solidarity Mutual Aid Network, which has been welcoming the asylum seekers arriving on buses since April. So the Migrant Solidarity Mutual Aid Network consists of over 20 DMV area community organizations and hundreds more individual volunteers who are committed to supporting migrants being bused to DC by Governors Abbott and Ducey, anchored by Peace House DC, Beloved Community Incubator, East of the River Mutual Aid, Sanctuary DMV, DC Incarcerated Workers Organizing Committee, Free Them All Virginia, and Conscious Community Action Together. The network has really been showing up to welcome our new neighbors through a framework of mutual aid that prioritizes dignity, compassion, and caring for those arriving as we would hope to be cared for ourselves. So the migrants that are arriving are fleeing violence, poverty, and instability, and are often robbed, assaulted, and placed in extraordinary danger in their journeys to the U.S. And once they arrive to the U.S., families are often separated in border facilities, detained in inhumane conditions, and many face abuse by border agents. Once CBP processes and paroles them into the United States, they're released to respite centers in Texas and Arizona, where they board the buses to DC. I think it's a little bit important to hold this uncomfortable contradiction as we're having this conversation, that we know that Governors Abbott and Ducey are busing people with sort of the worst intentions, guided by, xenophobic, invasionist rhetoric. But when you talk to the people, many here who are arriving are really grateful for the buses for helping them get closer to their final destinations, particularly when, so many are arriving with little more than the clothes on their back. So buses from Texas arrive almost every single day except for Monday nights and Tuesday mornings, and typically arrive at Union Station either between 8 to 10 p.m. or 6 to 8 a.m. And the vast majority of people arriving on the buses don't have support systems here in the area. Most have plans to travel onwards to other destinations along the East Coast, like New York, New Jersey, and Maine, while others are seeking to go further places like Ohio, Kentucky, Florida, Illinois, Montana, or sometimes even California or Washington State. We'd estimate that about 15% of those arriving have plans to stay in the region, but don't have anywhere to go and need long-term support. So when buses arrive, our network meets the buses and explains that we're volunteers that are here to welcome and support them. For morning buses, we escort people to various churches in DC that we've built relationships with to offer respite and do intakes. This network of churches and synagogues offer their large spaces for respite, mobilize their congregations to be volunteers, provide food, or offer housing. We're also in touch with churches in Fairfax that are interested in stepping in to support as well. But things are more challenging for evening buses, where we escort people into Union Station to proceed with the intake process. Our amazing churches are really only available during the day, so we're left using the public space at Union Station, where it's really difficult to have confidential conversations and coordinate services. About half of the buses are arriving in the evenings, and the migrants step off tired, traumatized, and really with nowhere for respite. They're in the really uncomfortable position of being rushed to try and immediately get on another bus to their final destinations, or struggle to find a place for the night. Local shelters are typically full by 7 p.m., so there's literally nowhere for them to go. We pool resources to put them in hotels, but it's costly. And this is really why it's so important for local governments to step in to help with shelter, respite space, and other resources. So then during the intake process, the asylum seekers are really asked about their needs and plans. Some people need assistance communicating with families to help them get to their final destination, which is why support with purchasing things like cell phones is so important. Many don't have phones or were robbed on their journey to the US. Others need assistance with purchasing tickets and guidance to get to their final destination, which is why money to support ticket purchases is such a substantial need. Others arrive with nowhere to go and need some support to figure out their new lives here in our communities. However, there's no resources for those that decide to stay long term in DC. We've had multiple occasions where migrants were denied from local shelters, and even when they are able to get in, the shelters are really ill-equipped to understand the particular needs of recently arrived asylum seekers. We're told time and time again from the folks arriving that's like really the first place in their journey where they're treated with kindness. We work with local partners and immigrant chefs to ensure that the folks arriving have yummy food, a safe place for respite, and access to hygiene kits, clothes, and medical and emotional care when they're needed. We work to help find and reunify family members who have been separated at the border. We ensure people have accompaniment to embark on the next stage of their travel with safety and some petty cash in their pockets. For those that are staying in the area, we do the best we can to help them settle. Some people are staying in local shelters, others in hotels or the homes of our volunteers. We support them to navigate the local social services in the area, find opportunities for community connectedness, and of course, accompaniment and access to legal services for them to pursue their asylum claims and comply with their immigration reporting requirements. But really, so much more is needed. What we thought was going to first be a short-term stunt by Governor Abbott is actually proving to be long-term. In the early days, we'd receive 1 bus a day with 20 or so people. We now see 2, 3, or 4 buses a day carrying as many as 160 adults and families, including infants. Since April, we've welcomed over 130 buses with over 4,000 people. But just this morning, 4 buses arrived with a total of 153 people. This afternoon, there's a bus coming from Arizona with 40 people, and we may even get additional buses this evening. We've heard that a 3rd location in Texas is considering busing people to DC, and Governor Abbott has budgeted for a total of 900 buses. The DMV community has really come together really loudly and clearly to say that we welcome people here with dignity, but really after 4 months, the volunteers are tired and our capacity is waning. Last week, a lot of our core volunteers were exposed to COVID and needed to quarantine. We were low on funds and capacity, so our network took 2 days off from welcoming buses to rest, reset, and still work to build long-term systems. And what we found after returning 2 days later were dozens of asylum seekers stranded and sleeping at Union Station. The region can't really rely on a volunteer network to carry the load. We need local governments to step up. Cities at the southern border have been doing this for years and can really be a model in how to respond. Just last week, a large migrant shelter opened up in San Antonio. That's a partnership through FEMA and the city of San Antonio. The city also staffs a table at their local airport to accompany migrants who are getting on flights. So the things that you all can do, the things that we need is we need a permanent respite space in DC and additional short-term shelter capacity. And throughout the region, we need medium to long-term housing and significant access to social and legal services, resources that can and should support both those that are newly arrived and the already unhoused community members. And we know mutual aid will always be there to support. It's what we do, but we can't do it alone. I'm going to close with really quick and empowering numbers for y'all. So we recently learned that people have donated about $160,000 to Governor Abbott's effort to bus people from Texas to DC. But we, the DMV community, have raised over $300,000. So what this means is that our communities, your constituents, are making a clear statement. We want this to be a region of welcome, and I hope you'll join us.
Thank you so much, Amy. That's really a helpful landscape. And I know Tatiana's been having some connectivity issues. I think it would be worthwhile to pull up her slides just so we can see them.
I am here.
You're here, great. Okay.
I'm on. Yes,
You're on
I'm
the
here
phone
on
now.
audio. I don't know what's going on with my internet, but can you guys hear me okay?
Yeah, we can. And so we're on your slide that I think was the one that you were trying to reference before, coordinating and aligning relief efforts,
Okay.
nonprofits initially
Yeah.
stepping in to cover gaps.
Yeah. Okay, perfect. So I think Amy already spoke over the response from the nonprofits on the ground. but what I was going to tell you a little bit about the work that SAMU does internationally and locally. We serve communities in crisis throughout the world, and we also have a lot of experience working with refugees and migrants. We were actually from February to June. We were in the Ukrainian border supporting refugees escaping the war. And when the buses started coming from Texas, our work in DC has been centered into opening a shelter for unaccompanied minors to fill the gaps that we're currently in the system of unaccompanied minor shelters. But this really fit with what our mandate is and the processes that we're familiar with. So what we did is we connected with some of the local nonprofits that were providing services, and we were able to work side by side with Catholic Charities and Caritatives for a couple of months on a volunteer basis to kind of understand what was needed to serve this population and what we needed to do to develop our plan. With this information and the seeing what was happening, we were able to present a grant proposal for FEMA, and that's how we landed in the funding. For this, the commitment and the support from Montgomery County was crucial to be successful and to have what we have today. How? Because, they provided the initial resources that Vera explained earlier in the call, and they've also made a space available for us to use as respite care. So currently we have a space in Montgomery County that hosts up to 50 migrants per night for respite care, and we're prioritizing women and children for this shelter. Here we give them clothing, space to shower, space to sleep, a space to connect with their relatives within the United States to come up with a plan for what their next steps are as they start their process here. So on June 21st was our first night opening, and that also happened to be one of the weeks when the number of buses increased exponentially. So we saw in a period of, I think, 48 hours nonstop buses coming morning, midday, and evening. So we really had to take a moment to breathe and look at what our strategy was moving forward until we could build capacity. Thankfully, our grant is not limited on funds, but rather it's reflecting on the number of migrants that we serve. So if we are able to have the capacity to serve more than the initial 15 to 2,000 that we had proposed, there is funding available for that. It's just, however much time it takes for us to build that capacity to respond. So hire the personnel that is needed, allocate the existing resources, work with partnerships, and as I think we all know, it's crucial to find a space close to Union Station so we can have an appropriate respite center. Our team is actively working on identifying this space. We're also working in collaboration with FEMA and other entities that are working with us, federal and local, to see how we can locate this space. So hopefully in the next couple of weeks, we will have that. If we can go to the next slide, I'll tell you a little bit of how our program is. So we have really three areas of work. We have the intake part, the respite, and then resources. Intake is really the work that happens mostly at Union Station, and that's where we greet the migrants, provide them with food, hygiene kits, and try to help them into coming up with a plan for their final destination. So we provide travel to a limited number of people. Unfortunately, there are some guidelines that we have to follow strictly because of the funding from FEMA. But we are also working to see how we can expand that. At this moment, between 30 and 40%, we've been able to have a little bit increase in the percentages of people that we can actually buy tickets for. We can buy, but there is a need for additional funding. So we're looking at ways to cover that. The respite center is currently the only space that we have is the one in Montgomery County that is always at capacity. We try to have a system to rotate effectively so we can open space for those that come. Most of the people that come from Arizona come in family groups, so a lot of them are going to the respite care for a couple of nights. And then we also work close collaboration with Montgomery County to repair those that are here for the longer term. Then on resources, we also have a team that's actively working on partnerships with organizations. Catholic and Catholic Charities, although they're not actively needing buses anymore, they are able to provide some legal services, some medical services, and provide us with volunteers when needed. And we're looking at developing partnerships with other organizations to expand those as well. This resource team also works on gathering additional resources, monetary and then in kind as well, clothing, food, snacks, anything that you can think of. So if we can go to the next slide and find the final slide from our side. Our call to action at this moment is, you know, as I mentioned, that need for the respite center in BC. We really hope to have that finalized soon. And I think we've all said the same thing, support the families and individuals remaining in the region. We think between 10 and 15% of the migrants that are arriving do choose to stay. So as a region, we need to come up with ways to extend services to them. Additional overnight shelter, if there's counties around the DMV that also want to provide respite care, we will be happy to work with them and see if we can come and provide services within that service, or actually do what we're doing in Montgomery County, which is we have a right of use agreement, so we can operate out of their facility. And then another thing that could be useful is support with staff recruiting. We've been working with Montgomery County also on their workforce program to be able to recruit new staff so that we can provide more services. I think in the first 3 weeks, we had about, SAMU took care of 1,500 migrants. That's only a small portion. So we need to keep growing our staff so that we can have more support. We're also working in collaboration with World Central Kitchen, who has been providing meals for migrants. And it's something that has been crucial to our services. And with that, I think we can have questions. I think we're all done, right?
I think so. Thank you for that presentation. And so here's what we're going to do. We have more than 30 minutes for Q&A, which is great and very unusual because we tend to spend a lot of time on presentations, but everyone was very succinct today. I have some questions. I know we'll use the raised hand function at the bottom of the screen. And if you would like to ask a question, please do that so I can see you. If for some reason I don't see you, just jump in when you think we have a break. So we're going to do Q&A here. And we're going to go to the next panel. And at the end of the meeting, we're going to workshop a little bit of a resolution around this migrant busing issue, about how we can work together as a region that we'll send up to the COG board. So if this topic is the reason you're here, please make sure you stay till the end of the meeting, because I think this is going to be a really important piece of work that this committee does. You know, I want to thank all three speakers. You know, here we have on this panel an example of a government response, an example of a nonprofit response, and an example of a volunteer-led response. It's really critical that we understand that all three of these are happening in the region. What we don't have here is any sort of real federal government response, I think, which is something that we can take up a little bit in our resolution. But in the absence of that, all of us are left being the first responders, right? So our governments, our constituents, our nonprofit leaders. And that's what you've heard today. One of the things I want to get at is where are the gaps? And we've heard a lot of really great stuff, and I don't want to diminish all the hard work that everyone has been doing, but we know that A, it's under great strain, and B, that it's not enough because of the enormity of this. So let me just ask this. Does anyone have a sense of right now what percentage of the buses or the people we are actually able to greet versus who isn't being greeted because of a lack of resources? Doesn't have to be percentage, but sort of a sense of that. Yeah.
I'm happy to start. I think our group is greeting about, I would say, like all of the Texas buses, except for there were like 3 days where the two that I mentioned last week, where our group had to take a rest, and then another sort of 24-hour period, sort of maybe a few months back, in which our group wasn't able to respond. But other than that, we're greeting 100% of the buses from Texas.
The volunteer network.
The volunteer network is.
Okay. And Samu, I mean, what about your, I'm sorry, I see that, Jerry, you have your hand up too. Okay, but I know Tatiana doesn't have all the visual cues. So, Tatiana, from the grant that you have, what capacity do you have for who's actually coming?
So right now we are meeting, I think the first 2 weeks we met 7 buses a week. The third week, the last 2 weeks, 3 weeks ago, we're meeting 7 buses each week. Last week we met 11 buses, and this week we're meeting all the morning buses from Texas and every Arizona bus. I think since the beginning of June we've taken, maybe to the exception of one, the Arizona buses. So it's
are
not.
Both of you then sometimes greeting. Sorry, go ahead.
Yes.
I was going to
No,
ask,
we can
is it
meet,
the case that sometimes you're
eventually
there
build up
together?
to meet 100%.
Okay.
Yes, there has been times for collaboration.
Got it.
So for example, like this morning, there were 4 buses, right? And so the volunteer network is out there, SEMO is out there. There's like a little bit of division of labor. You know, sometimes everybody goes to one of the respite churches. Sometimes, you know, SEMO will take folks into Union Station, and then our folks will go to one of the respite churches. So that's, you know, especially for Texas buses in the mornings when sometimes there's 4, it's, you know, it's kind of all hands on deck.
In 4 buses, how many people is that?
I think it was 153 this morning. A little bit over 150.
And Dira, do you have boots on the ground as Montgomery County at Union Station, or is it more of a receiving role in the county?
No, so we are our community partners and SAMU are the ones really doing greeting folks at the buses. We've pivoted our role that we show up once SAMU has they take all the individuals that they can to the respite center, they do their process. And once they sort of have weeded out the individuals who have a second destination from the people from the 2 groups, right? People who have a destination and then the people choosing to remain in the region, that's when we step in. They refer them to our existing network and we work with those families. I just wanted to offer, just sort of from the government perspective and the Google bird's eye view, while we're not meeting folks in the buses, there is a concern of sort of unintended consequences, right? Obviously, our volunteers, our community-based organizations in SAMU, they have bandwidth issues. They have to take a breath. They might not be able to meet every bus. So these individuals pop up in other places in our system. So through the homeless system, at hospitals, in various different places. So the bandwidth issues of not being able to greet everybody also has some consequences that are popping up elsewhere in our infrastructure.
And I would imagine public health consequences too, because we haven't really touched on this, but there are people coming with COVID.
Yeah, COVID, we've had a lot of issues in COVID, and I could let Tatiana talk a little bit more about that. And we also have people coming in with a lot of medical issues and medical needs.
Let me ask you, the COVID thing's pretty straightforward, I think. One of the asks that we have the DC government has asked our executive is to open up our isolation and quarantine sites for people testing positive for COVID. We'll see where that goes because those have some federal funding at least. Is Montgomery County right now the only jurisdiction you're aware of that is providing the types of supports you are?
As far as
Yes.
I know, yes, but I'll let Councilmember Jawando.
Yeah, go
he
ahead,
might be
Bo.
plugged into
Yeah.
a little bit more.
Yes, and I think, you know, one of the reasons obviously we're here today is to talk about that and the non-sustainable, the unsustainability of that, particularly with the numbers that were discussed by Amy and by Tatiana and Dira about how this is increasing and the layered needs. And I think the last point, I'm glad that Dira brought this up, of gaps in the system, right? You know, just that people are going to show up and it's inhumanly impossible unless you have a really robust coordinated network to receive everybody. And that will have impacts is already having impacts on other parts of the region as well. So it's just about getting in front of it. So yeah, my understanding is that despite, you know, not in no small measure to your efforts, Brianna, and your council, but right now we're the ones that are taking the brunt of that respite care.
I mean, you don't have to, you guys are the ones doing the work, so you certainly don't have to pat me on the back, but it's, this is one of the reasons we're convening, right? Is to figure out how everybody can work together in this response. It shouldn't be on one jurisdiction. We're grateful that Montgomery County has been leading on this, but we heard Tatiana say, having a respite site closer to Union Station would be a big deal, right? So if you're busing people from Union Station to Montgomery County further out and then back to Union Station just so they can get on a bus or a train, you're utilizing time and money that could be directed to another human being, you know, helping multiple people in that period of time. So I think we've got to think that through. And I don't have the answer. I mean, I can't conjure a government building that we own in the area, but you know, I also think there's an opportunity for us to put some pressure on the federal government who has a lot of property in that area. So we should think about that and how we use our power too.
And I was going to actually say, Brianna, if one of the related to that point is the FEMA is reimbursed. Maybe we could talk about that at some point with SAMU in particular.
Yeah.
They're funding some of that work that you're doing and the ability to ramp that up. But you're right, a center closer is critical. And the legal services and all that, you know, is another area that there's a big, you know, kind of gap to your question. So, you know,
Let's get to that. So Tatiana, what does FEMA pay for and what do they not pay for?
So they will pay for the space. At this moment, Montgomery County has not charged us for space, but if there is rent, they will cover that. They will cover meals. They will cover percentage of their travel. They will cover hotel accommodation for COVID positive. This was a change that we had after an incident where we had a gentleman COVID positive that we could not bring anywhere. We cannot bring someone COVID positive if we know it's COVID positive in DC to Montgomery County. Our shelter in Montgomery County does have a wing for COVID positive, but that's another story. They cover hygiene kits, they cover staffing, they cover security, they cover a lot of the basic needs. Communication, so we need Wi-Fi for the migrants to be able to connect to the internet and call the relatives. It's also good to a good point to know that there is internet access in the buses, and although not all of them have cell phones, a good proportion of them do. So they are already trying to connect with relatives, and the federal government has said that they will provide funding if additional respite centers are identified. That could be with us or with any other organization that is willing to submit a grant proposal. This is not exclusive of SAMU. It's been mentioned in different meetings that the funding is open to other organizations that are willing to do that. Transportation to Union Station, to airports, it's also covered by this.
And thank you for that. And so it turns out Marianne Tierney from FEMA is with us as well. And she just put some information in writing in the chat about some of the things that are covered. But if you want to chime in, Marianne, about how FEMA's thinking about this issue, it would be really helpful for us to understand, because I know that we need the help.
Yeah, hi. Happy to, wait, I was on video. There you go. Hello, can you hear me okay?
Yeah.
Great. All right, well, I have the wrong video. Switch here. Okay. So I think I put in the chat the eligible activities for EFSP, and if I get an email address for like somebody who could circulate it, I have the notice of funding opportunity for FY22 EFSP funding. That way everybody could take a look at that. And government entities are eligible applicants. So that is an opportunity to avail yourselves of funding for these for the eligible activities that I listed. In terms of federal space, so the federal, I think one thing I want to say is that the federal government has very little levers that we can operationally pull once an individual is released from CBP custody on parole pending the outcome of their immigration hearing. So the primary way that we support NGOs and local governments with the individuals who are in their communities is through the Emergency Food and Shelter Program. We don't really have an operational footprint, right? So we don't open shelters, we don't operate transportation, but we will pay other people to do that. In terms of federal space, we are not in a position where we'll be able to say lease a space. But what I have been working, I have my team in FEMA Region 3 working with Tatiana's team to identify their requirements. And then I'm going to have GSA, who's agreed to do this, do a market survey around Union Station. And we'll see if there's something that maybe SAMU could lease for this purpose. So that's an area where we're trying to be helpful, but we're not going to be in a position to lease that space. And my purpose here today was really to hear what you guys are talking about. The Department of Homeland Security and the White House have asked me to get more situationally aware, and where we can connect people and support, well, I'm doing that. Like I have a voluntary agency liaison assigned to help SAMU and the Texas and ARA NGOs coordinate with each other. So we're doing what we can to support, but I just want to be upfront and direct with people. There's going to be like a limit to what we can do. And primarily that limit is operationalizing any activities. So I'll stop there and see if there's any questions.
It's really helpful to understand, because I think in my mind, it's like FEMA responds to crises on the ground all the time. Why can't you have boots on the ground here? But you're saying that this division that serves this population doesn't operationalize in that way. But I'm very encouraged to hear the GSA survey. How long does something like that take?
Well, so I know Tatiana's on the line, but we're working with her team to get, like, I have my voluntary agents liaison and the FEMA logistics team are going to talk to SAMU as soon as they're ready to talk, understand what their space requirements are. Then we're going to take that, kind of translate that into GSAEs, and then give that to GSA. And when I talk to somebody senior at GSA, I mean, it will not take weeks for them to do it. They can turn it around pretty quickly. But that's just going to be a list of leads. Like SAMU is still going to have to go and talk to the lessor, and the lessor is going to have to be willing to do that. And the space will have to be suitable. For example, SAMU looked at a space, that space had mold. Anybody here who's done anything with facilities know that space is a non-starter. So now they're kind of back to the drawing board trying to find a space. So I think if we could prioritize something, it's helping SAMU find a space that they can lease that's suitable primarily for day respite, but then potentially for overnight. But I want to confirm that with Tatiana. I don't want to speak for her and her operation.
Tatiana, you want to chime in on this at all?
I don't know if we lost her.
We may have. It's okay though.
Well,
So
while
let me-
Tatiana jumps in, Will,
Go ahead.
go ahead. I think we're about to say the same thing.
Go ahead.
Sure,
You
you
go
go
ahead,
ahead.
dear. Go ahead, dear.
While Tatiana jumps in, I know that there have been conversations with SAMU. I think it's not made explicit, so I want to make the implicit explicit. SAMU has committed that if there is another location or space identified, they have committed to operate and run that center. So just wanted to make that clear.
One
And
of the
then
things that I really appreciated about the arrangement between SAMU and Montgomery County was that Montgomery County was very deliberate in the parameters for the use of the space to make sure that it was humane. So that might be something, Will, that you want to share with the group at some point, sort of how you all, what Montgomery County put out to say, these are the guidelines to make sure that the people coming in our county are safe in the space that we're providing.
Yeah, I mean, yes, absolutely. At some point, we were fortunate. I think Dara talked about this. That we had a lot of things kind of that we had already started, and we have a new facility that is that we were able to use the space. But again, it's far. It's not ideal. So we need some, something closer. One of the things I wanted to zero in on from FEMA, just to confirm, is what I heard. If a private entity, it's great to do the GSA survey. I also agree that that's awesome, and the quicker the better. But if there was a privately owned building, right, that by or some entity or another nonprofit or church or someone, that obviously it has to be up to code and would have to be in the right state. Those entities or folks who own those buildings would also be eligible for your assistance as well, correct?
Well, not necessarily if it's just a space. So, SAMU is the funded NGO right now. We've awarded.
So they would
them.
need to lease with whoever that
It
person
would be, unless there was another NGO that was coming, because the border is a good example. There's a lot of NGOs that operate at the border. Some of them, in the same jurisdictions, right? So you've got NGOs in Yuma and NGOs in El Paso and NGOs in Brownsville. They're all operating. They're receiving EFSP funding stream. They're operating their own facilities. So if there's an NGO that has a facility that could potentially support, they could put in an EFSP application. Now, what I would say is that we've funded SAMU, and so a question we're going to have is, how does this relate to the funding we have already provided? And so my advice would be to lean in on using the SAMU funding to find a facility that they are willing to operate. If that is not enough in terms of capacity, then of course there could be conversations with the national board about we need additional capacity, additional NGOs. So I don't know if that's helpful, but like in terms of just like a off to the side facility, you would need the wraparound capacity. They'd have to demonstrate that they can do that, and they'd have to be tied into this network.
Yeah, good. Thank you. That's helpful.
And SAMU has been really trying to get a lot off the ground because they didn't have much of a footprint here. So I do think here's one question I have. So my understanding is United Way is the fiscal agent for SAMU. I'm not sure your familiarity with the
Yes.
grant. Okay.
Yes, I'm very familiar with this grant. Yes.
You are great. I feel like you and I are going to spend a lot of time together in the next couple months. I'm excited to meet you. So, if United Way is the fiscal agent and they have other nonprofits that they work with, is there sort of a shortcut there if they wanted to engage another one to work with SAMU under their fiscal sponsorship of your grant?
Yeah, and that would have to be, obviously, I can't speak for the United Way. They'd have to agree. Yeah, they'd have to agree to be the fiscal agent. And again, I would encourage, just even based on this discussion, like we want to leverage, right? We don't want 15 silos of excellence now operating, because that's even going to be more challenging to, herd. I don't want to say manage, because I think this is a very dispersed network of people who have their own kind of intents and authorities. So we want everybody to be kind of working in synergy, right?
Mm-hmm.
And the way I think to do that is to think about how all of this funding fits together like a puzzle. So I understand now there's a lot of, I can hear it. There's a lot of concern. There's a lot of capacity issues. My advice would be, just in the rush to kind of get better order to this, to not make choices that end up making you worse off in the long term by having this very fragmented, disjointed network.
Always good advice.
Yeah.
A few of us have been talking a lot, so I want to make sure we're not dominating the conversation.
Yeah, could I elicit one thing? It's actually the last thing in the bullet here. Transportation services. I think it's really important to point out the vast majority of folks who come through do have somewhere to go, and that this is their first stop, not their last, and that the FEMA reimbursement is only covering 30% of the transportation costs so if you come into DC, you're at the respite center in Montgomery County and you need to get to to Atlanta, the delta between that cost, that will continue to grow and is being covered right now by the great group of nonprofits and others and people who are raising money. But that's going to become a burden as well. And I just want to raise that because from a funding point of view, I think that's going to be a significant challenge. It is already becoming a challenge, but it will become more of a challenge as we go along.
Yeah, and we've seen a lot of private fundraising for that, right? So the Mutual Aid Network has done a lot of fundraising for that. I know in the outset, and Abel Nunez is with us, I think, for the other panel, but in the outset, Pat Essen and Catholic Charities did a lot of private fundraising for that. And given that United Way is the fiscal sponsor for SAMU, I do think we as regional leaders might have an opportunity to talk with them a little bit more about whether there's a greater role they could play. I mean, I know we're always trying to figure out government solutions because that's who we are. But those philanthropic solutions really can help us fill some of the gaps. So I think we should, maybe I'll enlist my co-chairs to try to take a meeting.
Absolutely.
And speaking of co-chairs, Penny Gross, right on time. Oh, sorry. Go ahead, Tatiana.
I have just one comment on the travel. What we are seeing though, as we're implementing the guidelines, is that a lot of the families that come that have sponsors do actually have means to pay for the ticket. So we don't need to cover 100%. We need more than that 30, but it doesn't necessarily have to be 100%. Now, once we sit down with them and ask them, they do have means to get those last tickets. And the other thing is to kind of think, to be cautious, not to just charter buses to there's a lot of people going to New York City. How do we handle that so that we're not doing exactly the same thing that Texas is doing, with busing people without connections? And ultimately, the one last thing is our organization has been working with entities on the border and with connections from FEMA to learn really how the respite centers that are working in the border operate, because they don't offer transportation. So really trying to see how to replicate, supplement where needed, but really work on with those same guidelines.
I thank you for that. I think I might, Penny, if you don't mind, just let Amy go, because I think she was responding to something, and then I'll let you take us in another tack.
Yeah, I just wanted to respond quickly to this point because I think it's really important. So I can share personally, I've been doing similar work to this since probably around 2015. And I remember at that time, particularly when we're looking at asylum seekers during that time, the vast, vast majority of the folks that were coming into the US to seek asylum had sponsors in the US, had places to go, had families to bring them in, and it would be one family out of every, few hundred where we had to say, okay, you actually need shelter space. Actually, you need folks to help you. And, I think this is both reflective of the folks that we're seeing coming to DC. And when you talk to, folks that are doing this work across the border, is that's actually shifting. And there are more people coming to seek asylum that don't really have anywhere to go. Even the folks that are going to New York, it's because they want to go to New York because they think it's a place to go, not because they actually necessarily have families there. And so, part of the work that we're doing is helping them find shelters in New York, in Ohio, in Kentucky, Florida, wherever it may be. But I do think that it's important for us to recognize that there is this sort of larger issue at hand in which the populations that are coming increasingly don't have sponsors in the US. And the system is not really set up to support them, both at the federal level and the local level. And so it's a little bit of that creating of solutions that we have to do here.
Thank you for that. I appreciate the perspective over the time that you've been doing the work. Penny, love to hear from you.
Well, thank you. In a way, as we're having this discussion, there's a part of me that wants to say COG needs to take a position that whenever folks are trying to make a point with the federal government by sending people to DC, and it doesn't matter who they are, they're actually impacting local governments. They're not really getting their message, isn't necessarily getting across to the feds. But that's our challenge as the region, as the National Capital Region, because that's what has happened for years. My question actually builds a little bit on what was said before, and that is, do we know the number, do we have any percentages or any idea of how many people actually are staying in the region, are remaining here, so that we sort of take that long-term view instead of a temporary piece? What what happens with our local abilities to address the various issues. In talking to folks in Fairfax County, you know, we are a welcoming community, but we haven't taken on a specific role here to greet buses and so forth. We are dealing with a lot of people coming to Fairfax County and needing similar services, but not necessarily coming on buses. So, number one, do we have any idea sort of the long game here for localities? And then also, it's summertime right now, but if there are so many families coming through, what is the impact going to be on our school system? Because in the summertime, we don't worry so much about where the kids are going to be doing. But if this continues, we have another challenge here with how do the families connect with the education system? So I just wanted to put those two up there. One we may have an answer, and maybe the other one is something we have to put on a list somewhere to address. Thank you.
I'm happy to start answering that question, but I think your question is a really good one and a really hard one to answer, because the folks that are staying here, the majority of them don't have folks, and so what we're seeing is typically between 10 to 15% of the folks that are on the buses come here and say that they're planning on staying here. But things get a little bit complicated after that. Sometimes folks say that they want to stay here, but then when push comes to shove and they realize that, you know, things are hard here, it's expensive, yada, 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 they'll say, okay, but actually I have like a cousin in Montana. Can you help me get over there? And then the reverse happens too, is that we'll have people and say, I have a cousin in Kentucky. They go to Kentucky and then the cousin can actually provide what they want to provide, and either they contact us and say, hey, can I come back to DC, or they, you know, find a way to come back to DC, and we'll find them at Union Station and we'll be like, didn't we just see you like a week ago? I think the other thing to add is that obviously people are coming, you know, on the chartered buses that are, you know, being brought here by Governors Abbott and Governor Ducey, but we're also occasionally seeing people that are, you know, hopping on Greyhound buses, you know, at various aspects, you know, from the border that are coming to DC because they just, you know, this is an area that you know has a long history of welcoming folks, and so they say, I want to go to DC where I can be welcomed. And so I think it's really challenging to answer that question. And then on the school piece, I will share that we've, like, at the end of the year, you know, when this first started happening, we were doing a little bit of hand holding with individuals to try and get their kiddos enrolled in school. And I think it will be a challenge. I will share that the folks that are coming are not actually undocumented. They are paroled here. So they do have government issued paperwork. It's the same paperwork that they can use to fly through TSA. So there is that. And we just had actually one of the folks that arrived a while back was pregnant, and so we just have our first baby of the bunch, who's beautiful, and mom and baby and the whole family are healthy.
Thank you for that response. One of my concerns, and maybe it's something that we put, you know, for future discussion, is we've got an immediate issue, but we also have to play the long game. So how do we do that here at COG and in the region to be able to not waste our efforts, but trying to sort of split it? What do we need to do right now? What do we need to do in the long term? Thank you.
So I asked Abel to chime in as well, Penny, because I think some additional context on, you know, where we are on that could help answer your question as well. So Abel, take it away. Don't forget to hit your button. Hate when that happens.
You guys hear me?
Yes.
All right, sorry about that. No, I said just want us to be cognizant that the flow that we're seeing is, you know, the Venezuelans, Nicaraguans, Cubans, and Central Africans. A lot of those is there's pent up demand for people coming into the country in the southern border, right? MPP, which is the program, Stay in Mexico program that Trump installed, and Title 42 have artificially held people at the border, right? What we're seeing, and I was in Del Rio 2 weeks ago, they're getting an increase of folks. So that's why we're getting more buses now, right? Because there's just more people coming through. This is before MPP is dismantled and Title 42 is taken away. We have, the largest population of immigrants are from El Salvador. We haven't seen folks from those countries, El Salvador, Guatemala, and Honduras. But when you have MPP go away and Title 42 go away, as a region, we need to be ready that what we're seeing now is going to be minuscule to what we will see then. Right. So as we're thinking about, what you mentioned about the school system health, it'll just become harder. For the folks that want to stay, there's a difference for those that want to stay that have family members to receive them versus those that don't have anyone. Those are the ones that are much more critical. And for those that have been doing this for a while, is what happened to the Central Americans that came in the early 80s. In the early 80s, Salvadorans started coming in huge numbers, but there wasn't groups receiving them at Union Station. They meandered, they went everywhere. And eventually that community organized itself and then began servicing. So what we're seeing now with the Venezuelans, these are the first of their folks that are coming. These are people that do not have a history of immigration. So it's going to be harder for them to integrate into the region. And that's why we're seeing them a little bit harder. So I just want to be mindful that as we're thinking about the long game, that in the short game, and I'm talking about 2 years, when Title 42 goes away, we will have a mass amount of numbers. So whatever structures that we put in, we need to put them in place now to facilitate that transition. In about a year or 2 years, it'll stabilize. But believe me, when Title 42 goes away, we need to be ready for that. So to the extent that we're having this conversation and that the local governments are getting ready, they will be there. And even if they're family members, they will still need other resources, healthcare, educational, recreational, name it, they will need it. And for those that do have friends, because what we saw a lot of them on the buses was like, I have a contact, I have a cousin. I give that a shelf life of about a week before they end up on the street, right? There is no security that when someone actually has a sponsor, that sponsor is going to work out. So it's what Amy was kind of saying. People think they have a plan, then the plan collapses on them, and then they come back to us. But we're still dealing with newcomers every day, right? So what's our responsibility to the ones we kind of saw move them on, but then are coming back to us versus the ones that are continually come on the buses. And so I want to kind of paint a picture of as we're trying to build this structure, this plane, we actually have to fly it at the same time, right? And so it's not creating right now efficiencies in the system. That's why it's very expensive in the way we're doing. That's why our organization has spent significant amount of resources, because we don't have a centralized space where we can kind of work from and build resources around it. We're kind of on the fly doing it, and it becomes that much more expensive. So I would say that we need to be ready as a region. We need to be looking at the trends of what's happening outside of the U.S. I know by and large we think of immigration once they cross the border, but we need to be clear what's happening right now in the southern border, what's happening in the countries of origin that will actually move more people in this direction.
Yeah.
Thank you for that. And I think some of what you referenced speaks to what we'll get to our next panel. We're going to end the discussion on this panel here, but I'm going to change the schedule a little bit around. And what I'm going to do is have us throw up the resolution because it's pertinent to this discussion that our committee is considering today. I'll note that our guests, you are welcome to be here for this discussion, but the resolution and its consideration input is only taken from members at this point. I'm going to read it because if you can't see this little tiny type, I want to give you the benefit of hearing it audibly as well. This is a resolution expressing support for legal immigrants arriving to the Washington Metro region as a result of policies implemented by border states. Whereas the state of Texas and Arizona have initiated policies seeking to relocate recent legal migrants to the United States from their communities to the Washington metropolitan region as a political statement of protest to federal immigration policy. And whereas the Washington metropolitan region is currently receiving several hundred migrants to the region weekly, who typically are in need of human services, including temporary housing assistance, food, clothing, transportation, and healthcare. And whereas a lack of coordination and cooperation among those states engaged in the transport of migrants, the jurisdiction of the Washington metropolitan region, and the non-governmental organizations providing relief unduly compounds the difficulties of those traveling to the region. And whereas the federal government has an obligation to act in support of local jurisdictions to provide the necessary and basic services required of the migrants arriving to the region, and whereas Congresswoman Eleanor Holmes Norton will introduce an emergency appropriations bill for the current fiscal year to provide additional funding for the Federal Emergency Management Agency's Emergency Food and Shelter Program for humanitarian assistance to migrants. Now, therefore, be it resolved that the Region Forward Coalition requests that the COG Board of Directors consider a resolution of the board expressing support for the funding efforts initiated by the District of Columbia's congressional representative, Eleanor Holmes Norton, seeking additional federal resources to sustain the human services needs of those arriving to the Washington metropolitan region. Request that COG staff continue to work with local human services directors, emergency managers, nonprofit relief agencies, and other appropriate organizations to facilitate the coordination of policies, programs, and response efforts in support of the migrants. And request that COG's Human Services Policy Committee consider this issue at an upcoming meeting to further explore opportunities for establishing partnerships and coordinating efforts which result in increased supportive services. With that, I ask, are there any changes that the committee members would like to make to this resolution? Penny.
This may be very picky. In the first whereas, have the states of Texas and Arizona actually initiated the policies, or is this the governors of the two states? Because if this is a political thing, I'm concerned about bringing an entire state into the mix if it actually is the governor's political ploy rather
Paul,
than.
can we make that change to governors? Great.
Yep, sorry, I was having.
Without
trouble
objection?
reading.
Any objection?
No objection.
Further on, it does say something about the states, and I think that's okay, but because it's a lack of coordination and cooperation among those states engaged. But I do think at the first whereas, thank you very much. We need to put it back, put that political piece back where it belongs. Thank you.
Any other edits to the resolution?
No.
I am going to move that the COG Region Forward Coalition adopt this resolution as amended. May I have a second?
Second.
All those in favor indicate by saying aye.
Aye.
Aye. Any opposed? Any abstentions? Hearing none, the resolution is adopted unanimously. Thank you very much. Well done, team.
Brianne,
Mm-hmm.
thank you for that. It was really good. And I just wanted to make one kind of closing point before we transition to the healthcare panel. Just to kind of bottom line it from Montgomery County's perspective, you know, and really appreciate this conversation. We need another respite center in DC, and the support for, we have about 57-ish folks that are in Montgomery County right now that are not moving on, that are seeking to stay, and that number is going to grow, and we will be incapable of sustaining that level of increased number, whatever that percentage is. And you take, I don't have the math in front of me, but 57 of how many have come through, and that number going up. We're going to need regional support, to Abel's point and to the point that we've all been making, and to Penny's point, to make sure that we are dealing with this in a humane systemic way as these numbers go up, and it's going to take coordination from all of us. So I just wanted to kind of just really make that point about, and that is going to impact the school systems, our homeless systems, all those systems, and we're going to need to work together, federal, state, and local on that.
Here, here. And also, I know you wanted to invite us all to a site visit to the respite
Yes.
center.
I would love to do that. Yeah.
So I think anybody who's interested, we can ask Jenny and Paul to send an email out about that. And also anyone who wants to go together to Union Station to greet migrants and maybe volunteer a little bit and see what the boots on the ground are doing. We can coordinate both those. Maybe we can open it up to the full COG. We'll see.
Absolutely.
Thank you so much, everybody. This has been excellent. Now, we have another really important topic today, healthcare access for our immigrant populations. Very much speaks to the transition we've been talking about when folks stay, and what we offer them in our region. I'm first going to welcome Dr. Cully Elliott and Marissa Parella to discuss the many services provided by Mary Center, the flagship of which is here in Ward 1 in the District of Columbia. And then we will hear from Terry O'Hara Lavoie, co-founder of the Culmore Clinic. So Dr. Elliott, I will hand it over to you first.
Thank you. Thank you very much. Number one, I want to thank COG for asking us to present today and being a part of this. And this is my first opportunity to participate in any COG meeting as the CEO of Mary Center. And I can say that I am very humbled, but I will also say that this is hard work that you all are doing. This is hard work to discuss all these impacts. And as we talk about access for immigrants to health and well-being, you know, one of the things that was important for me was to include Marissa, because she's the director of School-Based Mental Health Fellowship Program. And what's really occurring out there is it's okay, we can talk about diabetes, we can talk about asthma, obesity, but we really do have to grasp mental health and the impact it is having on immigrants, because I do think that sometimes when it's done in ways that is not consistent with the cultural nuance of interacting and engaging with them, those things can be overseen and they don't get captured. And it's something that's extremely relevant. And you'll see that when Marissa gives her presentation today as part of this, how it does make an impact. And so, you know, for those that are not familiar with Mary Center, I'm going to briefly go through it very quickly. Marissa, could we go to the next slide, please? We started in 1988 with a nurse working for the Department of Health, Maria Gomez, who focused on immigrant women from war-torn Central America who were pregnant and they were not getting the care they deserved. She partnered with midwives and also partnered with Providence Hospital. We are a federally qualified health center. We're not faith-based, but it is called Mary Center. And there's a history behind that name where Providence wanted us to be St. Mary's, and Marion Barry said, no, I don't think so. And so what came out of that was a quick resolution, like, let's not fuss about a name, let's just go with Mary Center. And so what started off with a generous grant of $250,000 to take care of 200 pregnant women has now grown to approximately 60,000 individuals from 50 countries. And a large portion of what we do is to support the immigrant community. That is absolutely what we do, and that will always be the case of who we are as an organization. We have 5 full-service community health centers, 3 of which are in the district, 1 in Montgomery County, 1 in Prince George's County. And we have many school-based mental health programs, 26, 2 senior wellness centers that we work with the Department of Aging and Community Living in the District of Columbia, and a public charter school located at 3 health centers called Bria Public Charter School. Could we go to the next slide, please? So we focus on the social change model, healthcare, education, and social services. All 3 of those hit everything and every aspect of what you're going to see when you're an immigrant to this country. Next slide. And again, this slide is a little bit heavy. And so what I would like to say is that through the healthcare services that we provide, obstetrics, pediatrics, internal medicine, family medicine, LGBTQ health, infectious disease, addiction services. We have a sonography clinic for low-risk sonography. We have an ultrasound, and we also have school-based mental health, as well as dental health and other mental health services. We provide nutrition, chronic disease management, and we've been doing telemedicine since 2017, before the pandemic came into play. Next slide. The social services component, as you can see, is so very critical, as we just briefly talked about, with case management, legal services, benefits enrollment, which is extremely important and relevant in this conversation, because in many situations, immigrants are not eligible for benefits. And so depending on the jurisdiction, it does become problematic in trying to get them into care. And oftentimes we just have to write that care off. Next slide. And so definitely focused on how to look at the dual generation population, how to make sure we support both the parent and the child in terms of English literacy, parenting, early childhood education, preschool, and also working on trying to make sure that people are on a path to success. We do have a medical assistant program. We have a child development associate licensing program, and we're looking to add a dental assistant program. Next slide, please. Now, before I hand this off to Marisa, and there's going to be a wealth of questions that we would like to answer afterwards, the most important thing that's coming out of this is a clear example of the impact that we try to have and seek every day on the communities that we serve. When you look at Mary Center, 76% of our patients are Hispanic, 95% of our patients are minorities. And last year we gave away approximately $7.5 million in uncompensated care simply because there are a lot of individuals that are not eligible for it. In the District of Columbia, you have the Health Alliance program. For those that are not eligible for Medicaid, they do become eligible for the Alliance program. Montgomery County has the Safety Net, where you have maternity partnership. You have the child care program. And in Prince George's County, they're beginning to develop one. They are using COVID care dollars to support that, but it's still a need. Marisa.
Thank you. This was a great, really interesting presentation today. And as I was listening, I was reminded, I got to the city 20 years ago, and some of the issues that we're seeing today are similar to what they were back then, working with our immigrant population. So I'm going to speak a little bit about school-based mental health at Mary Center as kind of an example of how anyone who comes to Mary Center for care, there's really no wrong door to get into Mary Center. And no matter which door you enter, you can access all of the parts of Mary Center. So if you come in through medical, there's going to be someone asking you about other needs, not only in your family, but other needs that are beyond medical. So we do screening for mental health, referrals to social services, we ask about housing, and we're actually working on a social determinants of health pilot right now to make sure we're not missing anything, particularly in this kind of COVID landscape that we're working in. But I'm going to talk a little bit about school-based mental health today, because particularly for immigrants, schools are an incredible access point to find out what's happening with a family. And they always have been. And in fact, when we started this program about 10 years ago, one of the reasons we got started is because local bilingual schools in Ward 4, I know, we know Brianna Nadeau very well, had so many immigrant families coming in that didn't speak English, and the schools were really unable to meet their needs. And so they knew that Mary Center kind of specialized in working with immigrants, and they would call and say, can you please help us? Can you send us a mental health professional to work at our school? And so we were able to do that with just agreements with schools, somewhat informally, provide our outpatient behavioral health services within the school setting. And as we started to do that, we realized that there was such an enormous need, not only to serve immigrants, but really to serve all children with supplemental mental health services. And particularly with schools who were unable to really fully understand what was happening in the immigrant communities and were able to we had language access for them. So we started out that way, and over the course of the past 10 years have really expanded, not only into schools who needed us for bilingual services, but also in many schools. And then beyond the 26 schools that we're serving, about 4 years ago, the mayor made a significant investment and understood that schools were an important access area for students to get mental health services, particularly those who are under-resourced and maybe aren't finding their way back to clinics every week to continue with mental health services, but really having those be delivered in schools is really the best way to do that. So to co-locate these mental health services in schools. And so the mayor made about a $33 million investment to bring in other organizations to kind of mirror what we were doing and what the Department of Behavioral Health is doing to expand that. So we're very excited that that's happening. There's certainly a lot of challenges because COVID hit in the middle of that rollout of this program. But this slide kind of just talks about right now, our current reach is in about 26 public and public charter schools in various different neighborhoods in the city. We serve over 1,000 students annually for care, but we also serve students not only for mental health care, but we've been able to support them to get to other services within Mary Center. So we enter the schools with mental health services, but we're sort of like an octopus, right? We reach back into our clinics and we look, what other services do these children need? And I will tell you that one of the most needed services that we see is when we meet a child who has immigrated or is new to the country, and we do the intake with the parent because we see that they're having mental health challenges, we find a whole other host of ways we can help this family. And we feel very fortunate at Mary Center that we're able to do that. And usually the one thing they always need right off the bat is connection to benefits, because many of these children don't have that. They don't have their immunizations. They don't have a primary medical home. And so we have been able to link them back to Mary Center to connect them with those services, get them into healthcare, and frankly, serve their family. Their family also needs healthcare. And generally speaking, when parents have immigrated and have children, the first place they go is their local school. They need to get their child in school. And so it's a really great place to have children access care. You can go to the next slide. So what exactly do we offer in the program? These are just on your slide, some of the things that we're offering. Professional development for teachers, linkages to programs, the programs Dr. Elliott just spoke about, workforce development, adult education. We recruit families, particularly immigrant families, to sign up for our charter school, to learn English, to gain skills, because we know that serving the family in all of that capacity is really a whole child approach. A child who comes to us with mental health challenges, we don't really want to label that child with mental health challenges. We know what they're struggling with. They left their country. They potentially left their country in trauma, as we've heard today. They don't speak a language. This is a new school. This is a new place. They might live in one room with their entire family. Their parents are struggling and may not give them support. So the child really needs not only someone to talk to about how they're processing all of this, but they need their family to access services and care to reduce the stress level of their family, give them some economic security, and then they're able to really live as children in the schools, learning and growing in that way. So we have developed in the program, and we've particularly done this at Tubman Elementary School, which is also a community school, where we have sort of a way whenever an immigrant parent comes in who's new to the country to enroll their child, we have sort of a checklist we go through with them. So we don't just enroll them in school and say thank you. We enroll them in school, we interview them about benefits, we talk to the teachers about some special needs their child might have, we ask them about their housing. And so we have kind of an immigrant welcome committee, if you will. And we've piloted that at Tubman because we have the additional resources to do that. And it's worked out quite well. We've shared our resources with the District of Columbia Public Schools so that they could emulate some of what we've done there and maybe possibly spread that out. We do it in the schools that we're in that have significant immigrant communities. We don't stop at the mental health piece. We really try to support the whole family. Yes, Tubman's a great place, Brianne. You can move to the next slide. So we saw some really disturbing trends. This slide is really small for some reason, but we saw some really difficult trends that I won't harp on today because I know maybe many of you know about them, but certainly during virtual instruction, we saw mental health conditions worsening, but we didn't see it directly because students were not showing up for care within our program. And for many of the reasons you might expect, they had poor virtual connection, they didn't have consistent Wi-Fi, they didn't have privacy, they didn't have laptops. We were so fortunate to get donations where we provided many, I think 300, 400 laptops to families with multiple students. But many of our more under-resourced families were not able to access our care. But how do we know they were struggling? Well, we first know that many of those families lost more family members to COVID. So we heard about that. In fact, some of our clinicians had to shift from being mental health practitioners to connecting our families to funeral resources. And I will tell you that happened many, many times throughout the course of the pandemic. So then we know we're dealing with a lot of grief and loss and homelessness and children not having as many family members because many of their parents did pass away during COVID. But what we did see were high numbers of ER visits and hospitalizations. I'm sure you all read the articles about that in the papers. We saw low reports to child protection, but very high rates of children coming into the ER with severe wounds from child abuse. So kids were getting abused, but no one was hearing about it because they weren't in school. They weren't at practice. They weren't in their communities. So that's sort of how we began to realize that we were in a really difficult situation. And just the general social determinants of health, secure employment, secure housing. And I know I'm speaking to folks who know this, but immigrant families do not have secure housing. They're not on their leases. So a lot of the benefits that were afforded to many of our community members who are documented or were on a lease were not extended to our immigrant families that were undocumented. They didn't get a check from the federal government. We were a hub of getting cash to those families, so we were trying to support them as best as we could. But many of them live in informal housing situations that were not secure. And so they may have lost their housing, or they may have had just substandard housing or too overcrowded housing, which therefore increased their risk of getting COVID. So psychological toll on those communities, extremely high. And then after the murder of George Floyd, there was certainly sort of a very challenging response from our communities of color. And so we saw some really challenging situations and some higher suicide rates, higher thoughts of suicide rates. Then we came back to in-person school, and we really did a lot to ramp up to be ready to bring them in. I'm sorry, I'm not seeing all the questions, but I'll answer them at the end if they're in the chat. What we saw was a real dramatic departure of school-based professionals. So teachers were leaving their jobs. I lost a lot of staff, which is very unusual at Mary Center, to lose a lot of our practitioners, but some were afraid to go back to schools in person. They maybe had young children at home who couldn't be vaccinated. They chose other professions or chose to do virtual therapy instead with adults. So we saw that, and then you see sort of an inconsistent professional community in the schools for children. They saw lots of their favorite teachers leave, lots of turnover. Kids were coming to school anxious because their parents were anxious. So you had this potentiated anxiety in schools where teachers are anxious, students are anxious, principals are bogged down with managing COVID, quarantining, safety measures. So lots of distraction from learning and lots of kids who were behind in learning. So we saw all of that going on for the past 2 years. Next slide, please. There's not a ton of conclusive data on the outcomes, but we have seen some trends that have been documented, which is that young adults were doing particularly badly, particularly those who were living in socioeconomic deprivation. And you might imagine the ages of 16 to 24 is when you're really looking to move away from your family and think about your next step. And kids are really forced to they couldn't do that, right? Because they had to kind of, they were huddling up during COVID. They weren't necessarily going off to start their lives. The pandemic also had a more severe impact on children who had existing mental health concerns. So ones who were accessing treatment or were in school challenged but had a lot of supports, lost those supports, and their conditions became worse. And then counter to expectations, some children actually did a little better. Those children are probably clustered in higher socioeconomic brackets, but not necessarily. And some of those, I think, made us start to think about what's happening in our schools. Children's mental health and schools were we needed to increase mental health access in schools. We needed to increase capacity building in our schools to address trauma. And I think this kind of highlighted that for us, that some students, they weren't bullied. They slept better. They ate better. They weren't managing they didn't have some of the drama that happened in school. They didn't have some of the stress that frankly has come along since the rise in school shootings, whether or not it impacts our communities or not. Just the idea of that had kids quite anxious, particularly ones with pre-existing conditions. So we did see some of that as well. Next slide. Thank you. So what does Mary Center do with all this? And what does our school program do? Well, first, as I mentioned, our schools are just a great point of access for mental health services, but they're also a great point of access for us to get to know families where kids and which
Lisa,
is why I really
you're cutting out a little
believe.
bit. Can you
Yeah,
turn
am
off
I
your
running?
camera and see if that
Oh,
helps with your connection?
sure.
Okay.
Sorry, it seems clear to me, but we know that having a health center, a mental health program from a health center partner in school is really, we see it as a real asset, because we can provide so many other services that we recognize our children and families need. And I think, although the schools program I think is really special, we're co-located in 26 schools, I think that it is kind of a representation of kind of who Mary Center is overall. So if you came to Mary Center to join the teen program, for example, maybe you didn't have a mental health condition, but you wanted to join our teen program, which is a wonderful after-school program that 100% of our participants got into college this year. You, through that program, can be connected to mental health, or potentially school mental health if you need it, or health, or confidential services for sexual health. So it really is kind of an example of how Mary Center works overall, which is why I like to talk about it with Dr. Elliott, because this is just one example of, I think, how we've innovated that to be out in the community, bringing people in to get the full array of Mary Center services, because we know that if you participate in multiple services at Mary Center, you do better, right? You do better if you address all the sources of health, mental health, and social services. Next slide is sort of like, what do we do now? We know all this. We have all this information about our children and about our immigrant children, but really about all children, and how do we view moving forward in this, frankly, really challenging environment? I think what we learned after COVID is we need more accountable flexibility in our use of funds. We went from seeing a lot of students for mental health services and doing a lot of training, a lot of work in schools, to really people kind of disappearing, and us trying to find them in the virtual world. And we had to shift the way we did business. And so to be able to not be locked into a limiting way of using funds is really important for really not just COVID, but anything else that comes our way. Policies that support collaboration. Collaboration is something we all assume we're all doing, but it's not funded, because you do your part and I do my part, and have a grant from DOH and a grant from DBH, and we have those deliverables. But if you really want to tie all of that together, collaboration is something that needs to be supported through our policies and through funds. And then incentivizing innovation. This school-based program, we just sort of decided to run with it 10 years ago, and it's been really wonderful and successful. Not perfect. We have a lot to iron out. But I think Mary Center has a lot of, they really support ideas that are targeting gaps in the system that we see. And if we can incentivize people to do that through policies and funding, we're going to be able to address some of these wicked problems, as Robert Wood Johnson likes to call them, these just wicked problems that we can't seem to address. And I think the pandemic has helped us really understand and highlight the need for that. I want to also, as I end here, say that COVID was terrible for children's mental health, but I'll be honest, like, children's mental health was terrible pre-COVID, and suicide rates and kids thinking about suicide in DC, and I didn't include all those statistics, have been in some populations double the national average. So we weren't doing great. And some of that gets traced back to kind of the social media kind of explosion of 10, 15 years ago. But it was, I feel like we have an opportunity now to really leverage people's attention on mental health and really make it part of health. Yeah. And not some side project.
And hold that thought, because I want to get Dr. Terry O'Hara here. I'm sorry, I promoted you, but to Terry O'Hara, co-founder of the Culmore Clinic, who's also got a presentation here. We want to make sure we have time for reflections and Q&A. And so, Sarah, So Terry, go ahead.
Thank you. Thanks so much. It's a real pleasure to be here today. Thanks to Penny Gross for inviting me. I'm a constituent of Penny's, and I'm actually sitting around the corner from her office. Perhaps we should have coordinated something. I'm in I'm in my home office at the moment. And I must say, it really is a great honor to be on a panel with Mary Center. I've been a long observer and admirer of their work, and it's certainly been special. And I really loved diving in today furiously with all you guys are up to, and it's really important. Hello, my name is Terry O'Hara Lavoie. I am a mere co-founder of Colmar Clinic with no medical background whatsoever. So you really did promote me in a dangerous way. Colmar Clinic is an interfaith nonprofit healthcare clinic offering compassionate and culturally sensitive medical care, counseling, specialty referrals to low-income adults at little to no cost in Bailey's Crossroads. Next slide, please. We are an important part of the Northern Virginia safety net and the only clinic that provides intensive primary care services in this community. We operate 3 days a week. We have one location, Mary Center, and we operate in a church basement. The Colmar Clinic zip code 22041 had the highest rate of infection during the COVID-19 crisis. Bailey's Crossroads borders Arlington, and it has been documented as an island of disadvantage, where 21% of residents live in poverty, 57% of residents are uninsured, and 76% live in substandard rental housing in an otherwise very affluent region. Bailey's Colmar can be characterized as I mentioned, island of disadvantage. We have this important information thanks to Northern Virginia Health Foundation and VCU. It was called Getting Ahead, the Uneven Opportunity Landscape in Northern Virginia. And I commend it to all of you to really understand what's going on in our region that's really helpful in the Fairfax County and North Virginia region. As you look at this slide, note that the 57% uninsured rate in Bailey's Colmar is literally right up against an uninsured rate of 3% in Lake Barcroft. 57%, you walk around the corner, it's 3%. This 3% rate is a lot more typical of a Fairfax County neighborhood. And I just would note that Thurgood Marshall was one of Lake Barcroft's more famous residents. Next slide, please. Who we serve. 96% of Colmar Clinic's patients represent an immigrant population, most of whom do not speak English and require the clinic's interpretation services. Our patients are mainly Spanish speaking with Arabic and Vietnamese speakers as well. Even though 65% of patients are employed, their average income is below 100% of the federal poverty level. We accept patients up to 200% of FPL, but so many of them don't even make that threshold. Colmar Clinic serves adults only. It's an interesting contrast to Mary Center, which focuses on children and leads them into that care. In Fairfax County, we have the Medical Care for Children Partnership, a public-private partnership serving uninsured children. So Colmar Clinic chose a specific focus on adults because we knew MCCP was covering the kids. But we were seeing, I was involved with them, that the parents were the ones falling through the cracks. I note this for another reason. A hallmark of our model is to focus on what is not being provided. If the county or another entity is taking care of that service, we're not going to go duplicate it. We're going to try to leverage it for our patient access. Access to healthcare continues to be a crisis. Barriers to accessing medical care are legion: affordability, language, transportation. You guys know all of them. I shared some statistics here in this slide, but I might add that 29% of Bailey's Colmar residents live in overcrowded situations, and that the median income here is about $40,000. Right next door in Bailey's Crossroads, $193,000. I'm going to repeat that. $47,000. You walk around the corner past Lake Barcroft to Colmar Clinic, and you pass a population making $193,000. They walk. Our patients, 28% of them do not, in this region, 28% of people in the neighborhood do not have a vehicle. 2% of people in Lake Barcroft do not have vehicles. Many of our patients are not literate in their own language. It's not uncommon to learn that patients ended school in 3rd or 6th grade. High school education is not really routine for these folks. Can we go to the next slide? Colmar Clinic, the zip code 22041, had the highest rate of infection, as I mentioned, in the COVID crisis. When the pandemic hit, our patients were some of the highest risk of population or death. They are on the front lines as essential workers, living in shared spaces, needing to take public transportation, and unable to afford the high cost of PPE and testing, which was just not available when the crisis first hit. In addition, many of our patients are immunosuppressant or have comorbidities, putting them at even higher risk. Next slide, please. During the height of the pandemic, we surged from part-time to a full-time organization and posted 2,028 medical hours. No longer a part-time clinic. We provided 2,188 provided visits, 888 patient support calls, 167 counseling sessions, 931 grocery and medicine pickups, thanks to our partnership with Dar El Hijra Islamic Center and NovaScript Central. We did this with 4,723 volunteer hours. Next slide, where I can talk about the key aspects of the model we have as an organization. Volunteers. Volunteers founded the clinic in 2007, and to this day, it's significantly volunteer run. We rely on almost 70 active volunteers to take on meaningful tasks critical to our mission. They include doctors, nurse practitioners, medical assistants, counselors, nurses, medical interpreters, medical assistants, prayer ministers, and more. Each year, we leverage over $1 million in resources from both our volunteers and our partners. Next slide, please. In addition to be volunteer-driven, we are a collaborative organization. Colmar Clinic simply would not be possible without the unfaltering support of our partnering organizations that allow us to expand the services we offer our patients. Those partners include Nova Health System, NovaScript Central I mentioned, Fenwick Foundation, which delivers dental care on site, Quest Diagnostics, which subsidize our labs, the Virginia Association Free Clinics, and Marymount and George Mason Universities, where we help to train their nursing students. Next slide. I'd like to dive into how the supporters of Colmar Clinic work. I don't have time really to dive into how our partners help, and it's really profound and creative. And if there's time at the end, I'll dive in there. But really important, the most important aspect of Colmar Clinic is that we're an interfaith organization. We are not faith-based, we are interfaith. 19 different congregations support us financially or in partnership. They include some here, but not limited to First Christian Church, where we operate in their basement, Columbia Baptist Church, Dar El Hijra Islamic Center, Islamic Relief USA, St. Catherine Greek Orthodox Church, 8 Catholic congregations, including Holy Trinity in Georgetown, Holy Trinity Lutheran, Emmanuel Church on the Hill, Annandale United Methodist, Temple Road of Shalom, St. Mary's, and more. It's important to say their names out loud for the profound support that they afford us. I would note that one of the few, Colmar Clinic is kind of one of the few examples out there how the 3 great religious powers can actually come together cooperatively. In a fractured world, we own and value our ability to work across lines. Next slide. In designing how stethoscopes would land on chest at Colmar Clinic, we created a care model based on Cura Personalis, care for the whole person. We buttress this care with a focus on the social determinants of health and focus on helping patients navigate the bureaucracy of our health safety net system. We spend a lot of time with patients. New patient visits are 60 minutes. Routine visits are 30 and 45 minutes. I'm looking at the time. Should I take a break? We'll keep going. I just noticed.
Well, I'd love for you to be able to finish your slides.
Okay.
And then, but yeah, I think
we're trying to get to 10 minutes. Okay. Anyhow, so I think what was really important is that new patient visits 60 minutes, routine visits are 30 and 45 minutes. We need to spend time with our patients. Basic medical care, diagnostics, and laboratory testing. We distribute free COVID tests at home and teach patients how to use them. We provide counseling services, specialty referral dental care, as again in partnership with Fenwick Foundation. I think again to kind of echo what Mary Center was saying, we respond creatively to the diseases that our patients present for us. An example would be our diabetes group visits. We help them negotiate the bureaucracy, but it bears mentioning that when our patients show up for our diabetes group visits, it's the first time they've been in the classroom since 3rd grade or 6th grade, and they're adults. But that said, 59% of the patients in these programs, 59, almost 60%, reduced their sugar levels, 54% lowered their blood pressure, and 66% reduced or maintained a healthy weight. That's just with basic interventions, and it's because they've had no support before, and directed care works. We're a learning and growing organization. We're doing strategic planning while we're rebuilding, which no one should try at home. I have a slide. If you want to skip to the next slide around what other people and the takeaways of what other organizations are saying about us in our analysis, it just was affirming, and maybe you can take a look at that later, because I want to just, they tell us that they think we're doing a good job, but I just want to jump to the final slide, which is why you asked Mary Center and us to come in today. We'll skip to the next slide. There's a blank. Well, there we go. What we invite you to consider is collaboration, especially among churches and the grassiest of grassroots organizations. This is where the trust is. Without it, impact is limited. Literacy. Tailor services that can break through the barrier of literacy in one's first language. As mentioned, our Spanish speaker and Arabic speaking women, the most common education level is 3rd grade. They do not read or write in their own language. The highest is high school education. And I won't repeat the diabetes. Decrease isolation. Negotiating the complex healthcare system is hard for us. What about them? Think deeply about Wi-Fi access. Our patients have the right to access social services and online care, but they can't do it without stable Wi-Fi. Respond to the community by listening. Don't guess at it. Colmar Clinic went from 1 to 2, then 3 days by provide services for patients by listening to what our patients needed. We responded to their lack of access to dental care and the prevalence of diabetes by partnering with organizations. What we say to anyone who asks us, listen, look for friends, and then share the load. Don't do it alone. It's not rocket science. Thanks for listening. Oh, it's just 2:00. There we go.
Beautiful. Thank you.
Sorry.
I'm going to open it up to all of our members for questions.
Anyone left?
Either any of our panelists, because this is really important. We talk about healthcare in a number of different forums and committees at COG, but really, what's being provided to our most vulnerable residents is what we're talking about today through these incredible organizations. So I'm going to open it up. People can raise their hands. There was one question in the chat if you want to ask it live or read through. That was Conrad. Conrad's still with us. Go ahead, Penny, you kick us off, and then we'll go back to.
Thank you. I think it was fascinating to hear from Mary's Center because it's a much larger group. I'm intimately familiar with Colmar Clinic, and when it first started, there was a lot of naysayers, including the county, who said, "Oh, this sounds like a nice idea, but it'll never get off the ground." And 15 years later, they're doing just an incredible job with almost all volunteers. So it shows, I think, and we need to see, what can be replicated here. Mary's Center has certain structure. Colmar Clinic has a different structure. We serve different people, different types of people. But I think that there's something to be said for both. It's not just a matter of scale. It's really in who you're targeting. And from my perspective, Colmar Clinic is serving people who absolutely have no other access at all. And that's always been the way. And if we can, through the adults, sort of get to the children too, we know that there's some collaboration there. But I need to toot their horn. Colmar Clinic is just fantastic. And I was really glad to be there, sort of present at the birth.
Yeah.
That's great. Dr. Elliott, did you have something you wanted to add?
I know that we're over time, and I apologize for that. The one thing I wanted to say that during, since we're talking about immigrants, we took in Afghan parolees. We had many individuals that were from Central America that we saw. Things that would be very supportive would be having access to expedited intake when it comes to that. And in many situations, even when the Afghan parolees came through the feds by way of the county, and many times we would start the care, but then they would get transitioned over to a different jurisdiction. And it became kind of challenging because you only seen them for a snapshot in time. And that would be indeed the first time they may have ever even seen a physician. Translator services are absolutely needed. What would have made it much easier for us is if we had the capacity to just go out and find our own translator, because in many situations, the translator that came through for the Afghan parolees, where we'd have one in the beginning, but then after that, trying to get them on the translation line would take 30 minutes or more just to get one person to support that. And so in our mind, if we could hire our own translator, we would literally have a session to support immigrants that were coming through. And also specialty services, and trying to promote how we can collaborate with hospitals in terms of making sure that these individuals do not end up in the emergency room seeking care because they don't know if there's anywhere else to go. So if hospitals work with outpatient settings, then we can actually see a lot of stuff. And then going into tiered provider levels, because there's always an issue with access to a number of providers available, behavioral health, medical, dental. Many issues that we were seeing across the spectrum, not just with children, but everywhere, were issues that, again, never seen a dentist before, never seen a doctor before, a pregnancy that was planned, but the pregnancy had not been cared for by a provider, whether or not it's a midwife or a physician, very challenging. So funding to support access, telemedicine works. Embrace that, because we know the CMS is recognizing that they can see the video interaction similar to what we're doing right now, but they're not recognizing that audio makes a difference. And I choose not to call it telephone, I just call it televoice. When in med school, they tell you 80% of your diagnosis comes from your history. And so if you have an individual and you're talking to them and you can get them engaged in that process, you can alleviate so many different challenges that are right there just because you can get them on the phone. And so having the flexibility to do that makes a massive, massive difference. And so looking at cross-jurisdictional regulations and trying to find a way where we recognize that these borders are just lines in the sand. Many of these individuals, we may see somebody today and they may go across and then they're going to be they're going to be with Terry's organization. And
So this is a really important point, and I think gets at the heart of one of the things that we wanted to talk about today. So thank you for raising this. So I'll give you an example. So my family, my husband and I have sponsored 2 Afghan refugee families that are still waiting. Like, we've been supporting them in exile until they can get their parole, right? But we sat down and really mapped out, like, where should they go when they get here? Like, which jurisdictions have and I'm a District of Columbia representative of the government, and our default is, of course, they should come to DC. But what else is out there? And how do people make decisions about where to settle in the region based on things like healthcare, housing costs, etc. Now, this conversation is about healthcare. One of the things we wanted to sort of get, and the reason Mary Center is sort of an expert in this, is how does it vary across the jurisdictions, right? Like, I know very well Alliance, not as well as you, because you're implementing it, but from the legislative side. So what other jurisdictions, what are the healthcare options? It doesn't have to be just you, Dr. Tully, but Dr. Elliott, but how do people make those decisions, and what are you seeing with patients and the coverage they get across the region? Any insights you have into jurisdictions that are sort of thinking about doing more healthcare for immigrants, that sort of thing? And I know we were way over time, but this is too important while we have everybody together.
I would like to say there's a healthy competitive nature among the jurisdictions. So I think that they don't want to be one up. And so when you look at DC Alliance program taking care of individuals who are not eligible for Medicaid, it really does put the pressure on the other local jurisdictions. So Montgomery County has the Care for Kids, they have Montgomery Cares, and they have Maternity Partnership. Prince George's County is just now beginning to implement those kinds of strategies. I will say that the Healthy Babies Act is massive in the state of Maryland with respect to there shall be no woman who's pregnant, irrespective of where they come from, that should not have access to care. And then you look at the fact that any and every federally qualified health center cannot turn anybody away. you know, and so it is our job, it is our obligation to take them in and then seek if they're eligible for anything. And if they're not, then we put them on a slide. And if they can't afford it, then it has to be something that is not an insurmountable expense for them. And so, you know, we do get paid in that setting to make sure that we can take care of it. But it is advocacy. It is moments like this to speak to government and to speak to authorities where we can say, hey, how can we afford, how can we set aside resources for this community in that transitional period before they get to being eligible for service.
And I might add too, it's partnering again. I had mentioned earlier, but partnering with the smaller organizations, and you know, the work of Mary Center and a federally qualified health center, two awesome ones in Fairfax County. I can't tell you how much I respect their work. You know, some of, especially the newest of newcomers, these are larger organizations, and as welcoming as these entities are and that fees get waived, people don't feel like they have the right to not pay. So they don't go back to their appointment. They have to complete paperwork or show up at certain times. And that's a little difficult coming into these smaller groups in partnership with these larger ones. I mean, we will refer patients to Neighborhood Health, our area FQHC, but the vulnerability that these individuals are coming to this country with, and their ability to access even the finest forms of care is harder. And so across the region, you want to look to, Montgomery has an awesome coalition of nonprofit health centers. Their coalition is really organized. Northern Virginia, is a looser coalition of them, but they're here. And so it's just trying to find ways to integrate with them. And there's a willingness to collaborate, you know, with opportunities always present themselves, and we always do collaborate really well.
A great example is our site in Prince George's County. 80% of the women were uninsured who were pregnant. Mm-hmm. And during the pandemic, we had approximately 243 women who were pregnant with COVID, of which 134 we diagnosed and we cared for them. We did not lose any, but you can only understand the stress of being new to the country, not having COVID, but then being in spaces where you don't have the luxury of spacing out in your living arrangements. And then next thing you know, you find out you have COVID. And so there's a lot of opportunity there to help. Unfortunately, that help is definitely needed.
Thank you. That's wonderful. And there was one question from the chat that we didn't get to, which is, do either of your organizations use art as a way of reaching kids?
Use what?
Art.
Oh,
use art.
We don't serve kids, so.
Well, right.
Marisa might be able to
or anybody, I guess.
We love that though. No, we don't. We have one of our counselors is real committed to this, and so we're investigating ways that we could do some more arts. She even brought a brick to our doorway that just talks about arts. So it's on the radar, but unfortunately haven't been able to yet. It's great. It's a great way.
Well, thank you all very much, Terry, Marisa, Dr. Elliott. Really great to hear from you all on this. And that will wrap our meeting. We normally have a little time for jurisdictional updates. I apologize, colleagues, but so many of you stayed on, even running 10 minutes into the next hour, and that just really speaks to the depth and importance of the discussions that we've had today. I'm so grateful to all of our guests, panelists, and everyone who participated. Our next meeting will be Friday, October 28th, and it's focused on sustainability. And I look forward to seeing you all then. Thank you so much.
Thank you for having us.